6 months into the COVID pandemic, we are all facing a constant stream of difficult decisions. Should we send our kids back to school? Should we accept that birthday party invitation? When should we wear a mask? As you navigate these choices, tapping into the latest science on COVID can be incredibly empowering. My guest today, epidemiologist Dr. Caroline Buckee, can help you do just that. In our chat, we explore many of the critical questions that we need to understand in order to make well-informed choices. How does COVID spread? Can kids spread COVID? Which prevention strategies are the most effective? Can people get reinfected? We close by looking forward at the next 6 months and the key factors that will shape our collective fates, including vaccines, herd immunity, and politics. Dr. Buckee is an associate professor of epidemiology and associate director of the Center for Communicable Disease Dynamics at Harvard School of Public Health. She and her colleagues have played and continue to play invaluable roles in understanding this pandemic and informing public health policies. Let's dig in. Welcome to Get Real Health. I'm your host, Dr. Chana Davis. This show cuts through the noise to give you science-based insights from real experts so that you can make smart, healthy choices. Dr. Caroline Buckee, thank you so much for taking the time to chat today. I can't believe I get to have a real live epidemiologist in front of me.
Thanks for having me.
Yeah. I gave you a little snippet of my long list of questions here. So I promise you, I'm not going to hold you to this whole list, but I just want to cover as much ground as we can because there's just so much that we don't understand and so much uncertainty and so much confusion that anything you can do to help clarify will be immensely helpful.
I'll do my best.
Okay. So I guess the central frame that I want to build all of these questions around is balancing, the need to be health conscious and cautious and avoiding COVID with the need to, move on with our lives as much as we can and not paying too much of a cost for moving on. So I really want to help people, including myself, really make choices that are sort of as rational as possible. And to me, you need to understand what the real risk actually is as much as you can in order to be as rational as possible. So that's kind of how I'm trying to build this around. Does that make sense?
Yeah, absolutely. I mean, this whole pandemic has been about trying to balance individual responsibility versus public health response. So that definitely makes sense.
Yes. And we're at an interesting point in this pandemic where people are experiencing a sort of lockdown fatigue, and we're seeing second waves, and yet we are seeing public health officials hesitant to be as strict as they were initially because of a fear of pushback. Do you think that's is that real? Do you think this sort of perception?
Yeah. I think that what we've seen following the initial stage of lockdown and the subsequent reopening is that the whole response to this pandemic has become so politicized, and policymakers are trying to balance the economic and political climate that they're dealing with, the fallout from the lockdowns from before, and trying to balance their ability to manage compliance as well.
Yes.
The whole thing about public health is that it relies on trust and it relies on individual behaviors. And so understandably, policymakers are very hesitant to send us back into those early, really locked down phases. And I think with good reason. In fact, I think that, we know now a lot more than we did, and there is no reason that we can't continue to have some functioning of society that allows people to go back to work and get on with their lives while really making sure that people are compliant with the public health strategies that we know work to reduce transmission. So right. I think that that's an accurate representation of what policymakers are facing.
Right. So that's good news. So we're in a much better position to actually be strategic about what behaviors and aspects of society we allow to open and which ones we don't. And whereas initially we were just, you're flying blind, got to close everything.
I mean, I think we have learned a lot. I think what we've also seen is that in some populations, for political reasons, for reasons of misinformation, and online communities and so on. We've actually seen that people are very hesitant to take even very reasonable steps to prevent transmission. And so in some ways it's easier because we know what interventions are going to work well. But in other ways it's harder because we're seeing active pushback against even simple interventions like wearing masks. And so this is a big challenge for public health practitioners.
Yes. One of the things I'm hoping we can maybe touch on is helping people to, again, so sort of, I know nobody can pin a number on absolute risk, but I think people have a better sense of sort of the risk continuum. Like, I understand that outdoors with no one around me is less risky than indoors in an elevator with 20 people. But can you put some numbers on either of those? I mean, I know you can't make perfect numbers, but I think people really struggle and can be paralyzed by not having any sense of what the risk really is. And can we use public health data? Can the average person start to use public health data to wrap their heads around ballpark even? Or is that just too scary for you to contemplate people really, taking action on this highly available public health data?
Well, it's interesting because some aspects of the data are available and other aspects are not. So, for example, we don't have widely available sex and age disaggregated data for North America, for the US, for example. And that does make it hard for people to really come to terms with what the risks are. And we know that things like age and other comorbidities are very important in determining risk. And so I think it's not an illusion that it's hard for people to try to put numbers on these things. Apart from anything else, I think there are still many unknowns about the spectrum of severity and especially some of the longer term sequelae. So, some of the longer term health impacts won't become apparent for some time. And so caution is warranted. What I think has become more clear are things like which routes of transmission are more risky than others. And that can help people to get a sense for in their own lives what they may be willing to tolerate or not. So, for example, at the beginning of the pandemic, we were quite concerned about fomite transmission. That's, transmission on surfaces and so on. And it seems that isn't one of the major routes of transmission. But rather now airborne and droplet transmission seems to be more important. And so that's really changed our thinking in terms of the really key things that we have to take into account in our personal behavior. So that's indoor, crowding, duration of time that you're in an enclosed space, those kinds of things. And so wearing masks is obviously key for people, and that's become very clear during the course of the pandemic. And then apart from that, I think we have to make judgments based on the contacts that we have and who is high risk within those contacts. So which of our family members are over 65 or have other underlying conditions that make them particularly at risk, and tailor our behaviors accordingly with keeping in mind that we need to respect our communities and protect the most vulnerable people. So, wearing a mask when you go into a store is not unreasonable, I don't think. And similarly, I think as a community, as a population, we have to make some trade-offs. And if that means not going to bars and restaurants in order for our children to be able to return to school, then I think collectively we need to come to some understanding that that's going to be necessary to survive through the winter without catastrophic mortality, especially in communities that haven't really seen much of the virus so far. So they're not really, they're nowhere close to herd immunity.
Man, you've got me percolating a bunch of questions as you were speaking there. One that actually on the personal risk aspect of it, so how bad is it if I get it? How much do we have data on sort of age independent from comorbidities? Because of course you see all these comorbidities in older people, and so do we have data on just healthy older people and how susceptible are they, and how serious are the consequences?
I think, again, how people understand risk is really different person to person. So for a healthy individual, more likely than not, you will be okay if you get COVID-19 and you may well be asymptomatic, that is, have no symptoms at all or very mild symptoms. But that's not to say that we haven't seen cases where people are very severely ill, even people that haven't had, underlying conditions. So it's still quite early to say anything definitive about individual level risk, except that we know that, there are some kind of classic ones like age and, some other morbidities that we need to worry about. So I think, the key as well to keep in mind is that there's so many unknowns with this virus. And we've seen so much devastation in our communities, especially in our older communities so far. And the question is, what are we willing to tolerate as a society? And what does that mean for our own individual behaviors? So, all of these things are weighing up your own personal tolerance for risk and what that looks like. And it's going to vary person to person. But again, I think the public health response has to weigh up the broader risks to our society as a whole. And that's challenging, for sure.
What advice would you give to, parents that are, trying to just weigh the pros and cons of sending their child back to school and recognizing it's going to be a personal choice, but how do you approach that?
I think what we've seen around the US, for example, in places that have started to open, is that probably the biggest factor in determining whether it's safe to open schools is community level transmission. So how much transmission is there around in your neighborhood, in the people that live and work in the school, near the school. And that's, for me, one of the most important factors in deciding whether it's safe to send kids back or not. And again, that speaks to these societal level trade-offs that we need to make about, what we're willing to sacrifice for the sake of getting kids back to school. And, in a lot of cases that feeds kids from lower socioeconomic status areas, and it allows parents to go back to work. And, I think often the people that are being disproportionately impacted by kids not being at school are mothers, working moms. And so there's many layers to this pandemic. And I think community level transmission, making sure that that's as low as possible before schools start to open is the key. Like the schools themselves have to take steps. Ventilation is a huge one, having people wearing masks, and so on.
It would probably make you cringe, but I wrote an article back in June when my son was going back to school about sort of the logic that I tried to walk myself through in making a decision about sending him back for that precautionary period. And I basically said, okay, what's as local as I can get for a view of what is the local rate. And at that point, in Greater Vancouver region, we had about one new case a day in a region of 1.5 million people. We were seeing like single-digit cases per day, and they had been pretty low for a while. And so I tried to say, okay, let's just take the absolute worst-case scenario assumption that, again, that these numbers their actual numbers are tenfold higher because testing isn't perfect. And let's assume that it's actually been growing stealthily at some rate that is not represented in the recent data because of the lag, and it's actually been doubling every 3 days, something really preposterous. Then I take that number, say, okay, well, the real number is not 101. The real number is 100 cases out of 1.5 million people. Let's say my son is exposed to all 500 people in his school somehow. And then what's the percent chance that he's actually going to be exposed? And I came up with a very small number doing that kind of worst case estimation. So anyways, as an epidemiologist, what steps would you take, and maybe where did I go wrong in that logic, and what are all the unknowns that play into it?
Yeah, I think your logic is correct. I think the tricky part is understanding the reality behind the numbers that are available to us in different parts of the world and in different parts of the country. So confirmed cases is going to be a small fraction, but it's kind of hard to know what fraction of the true cases it's going to be. And so I think, there's a lot of these different metrics around, and it's hard for people, I think, to know what the testing criterion is in their area, how that's been changing, the extent to which testing capacity is keeping ahead of the epidemic, and, again, these are lagged indicators with respect to transmission, right? So what we know is that, you get infected, you won't get symptoms for about 5 days or so. And then, you get tested. Depending on the testing delays in your area, the test won't come back for a couple of days. And, by that point, you've been infectious for several days. And then, if you show up in the data, you'll show up, at that later date compared to when you got infected. God forbid you have to be hospitalized or you die. Again, that will take 3-4 weeks. So these lagged indicators are problematic. I think if it were me, I would definitely be looking at trying to understand what the local prevalence, local incidence was in my area. I would look at the trends. I think looking to see, are things going up? Have they been coming down? Are they staying level over the last month? Test positivity rates that, people look at a lot. That is quite difficult to interpret, actually. If it's very, very high, it means that your testing capacity is not working well. You're simply not testing enough people. But below that, it's sometimes difficult to interpret because you don't know who's getting tested and you don't know exactly what's going on with those numbers. So that's sometimes a little bit difficult to interpret unless it's very high, and then you kind of know that there's a problem. And then in terms of obviously deaths and things like that, the important thing to remember there is simply that it's lagged by quite some time. And so even if the death rate is very low, that doesn't necessarily indicate anything about your safety right now. Yeah. So I think you're right in kind of your thinking and how you would try to account for testing capacity and, the fraction that are asymptomatic and so they don't get tested for that reason. But all of these indicators are somewhat problematic and not the whole picture. And then I think the other thing is that parents really do have to look at their school's plan and see if it makes sense to them, and see if it addresses some of these critical issues about transmission, which is, keeping kids apart from each other. What's their mask wearing protocol? To what extent have they addressed the ventilation situation? So is there good ventilation in the classroom? How are they going to protect their teaching staff? All of those kinds of questions are also important. Yeah.
I know schools are also approaching this sort of pod size, pod consideration differently as well. I mean, I saw a New York Times article that did something similar. They said, let's say, what's the local infection rate? Let's add a 5x multiplier. Let's factor in the current growth rate and then try and arrive at a number of what's the chances that someone in your school is infected. And then they would basically divide it by the pod size as,
the problem with that, and to be clear, this is kind of what they're kind of doing an epidemiological model in their head, right? That's what that logic is. I think the problem with that is that epidemics spread through social networks, and they're very local. So in our models, what we do is we tend to, depending on the formulation of the model, is we tend to assume one well-mixed population, right? So those exponential growth models that you will have seen, they tend to assume that we've got kind of random mixing within a group of people, but we don't. And so the logic behind the calculation is not wrong, but you could get it wrong in terms of the risk because the structure of the social networks that underpin viral transmission are highly heterogeneous. And so, for example, we have college kids coming back to the Boston-Cambridge area from all over the US, and they may well be bringing cases with them. And the question for parents is, to what extent do we think the social networks of college kids and the social networks of the school kids overlap? For sure, once the epidemic gets out into the community, then and it starts spreading kind of freely in the community, then we have problems. But localized outbreaks are a slightly different thing. And so some of these aggregated metrics that you will see on public dashboards and public websites, they're aggregated to a level where it's kind of hard to make sense of your local risk. That's a sort of general problem for epidemiologists, right? Which is what is the denominator? What is the population at risk?
Yes, yes. I remember thinking along those lines early on when there were so many nursing outbreaks. It didn't seem to make sense to think of my local rate as containing that nursing home outbreak when it was really its own entity.
Right, exactly. So you have this tight-knit local community, and all of the social contacts and all of the locations where spreading is occurring are sort of contained. And then, of course, it spreads to the community through the workers that work in those nursing homes and so on.
What is the latest data that you're aware of on the extent to which children transmit, are as likely or less likely to transmit as adults?
So it seems as if children become infected at not that much less often than adults. So basically, children are not immune to this. They do indeed become infected. Of course, they don't tend to have severe disease, and they are more often asymptomatic and have no symptoms. And there's some evidence that they're slightly less infectious, but there's been some other recent data that shows that their viral load, so how much virus that they are shedding, may be as high as adults. So I think it's still an open question whether they are significantly less likely to be contributing to transmission, but they certainly can contribute to transmission. Thankfully, less likely to get disease.
Okay, that makes sense. We haven't, just changing gears, we haven't talked much about immunity, and I know that's on a lot of people's minds. In fact, just yesterday there was a story of supposedly the first reinfection, of someone in Hong Kong 4 months later. So wondering that the big question is, can people become reinfected? How long does immunity last, and how effective are the antibody tests in capturing that?
Yeah. So the reinfection of this man in Hong Kong, I think, is not necessarily surprising. There have been, hundreds of thousands of people that have had this virus, and we haven't seen an overwhelming number of reinfections, which we would have seen if there was no immunity. So this reinfection is not particularly surprising, and the person didn't have symptoms in this secondary infection, consistent with some immunity that's protecting against, very high viral load or pathogenesis. I think there is likely some level of functional immunity. We don't know yet how long it's going to last. That's a big open question. But I think there's a growing consensus that there is some functional immunity. Whether or not it will protect against reinfection or just against symptomatic disease, the balance of that is still an open question as well. And likely we'll see a spectrum in different people. But it does provide hope that, we will be able to make a vaccine, and there will be some amount of immunity that will protect people from the worst of this disease. Interestingly, what we're finding is not inconsistent with the kinds of immunity we've seen in other seasonal coronaviruses. Okay. So what the pattern of immunity so far is kind of, I think, hopeful. But it remains to be seen how efficacious the immune response is and how long it lasts. With respect to your question about measuring antibodies, it's important to remember that this virus, so you can imagine a virus as, having many different components. And your immune response similarly creates antibodies to different parts of the virus. And so when we go looking for an antibody response, we're looking for a specific type of response to a specific part of the virus. And because we don't know yet which part is going to be protective, we're not necessarily measuring the right bit. And so, just because you don't have antibodies doesn't necessarily mean you won't have some level of immunity. And again, we don't really understand the dynamics of immunity and whether it's waning and things like that. But there's measurement error as well. In just trying to figure out which bit of the immune response is going to be a good predictive biomarker of protection. And we don't know that yet.
So, is a generic antibody test just total antibody titer, like, again, without any specificity to what that antibody might be targeting within the virus, or is it more specific?
So, no, it's looking for a specific kind of antibody.
Okay.
And yes, it's tied to, so, you know, the amount of antibody you have will determine, you know, that's part of the test sensitivity, right? Which is, you know, it will have a limit of detection. Yeah.
Sorry, I didn't mean like total antibodies to anything, but are they pan COVID, or are they specific to any part of the SARS virus?
So they will be specific to this coronavirus.
Yeah. But again, there, as you say, there's other layers of specificity within that, but we don't have the knowledge enough to know which ones that might be.
Right, and there's different antibody tests that measure different bits of the of this coronavirus as well, that measure antibodies to different bits of it.
Right. Okay, that makes sense. And we didn't really talk about the whole T cell aspect, that the other layer. If you want to add anything there.
Just to say that again, we still don't have a really clear picture about the dynamics of the immune response, and, you know, the different, you know, B cell versus T cell aspects and so on. But it seems likely that we'll have some functional protection against, if not infection, then maybe then disease for some amount of time, and it remains to be seen how long. And again, the other thing to note is that the immunity that a vaccine elicits is not necessarily the same as immunity that you acquire following infection. And that will take some time to figure out as well.
Yeah, no, it's and I hadn't thought about this glass half full idea that if someone becomes reinfected but not sick, it's that's similar to what you might hope from a vaccine, I guess.
Well, right? I mean, ideally from a vaccine, you want to stop transmission. So really you want to stop infection. Rather than simply ameliorate the symptoms. But at least if we cut the morbidity and mortality rate, that will be something.
But I guess the fact that children have a high viral load but without disease seems like they're not really intimately linked.
So probably, I mean, in other pathogens, viral load does correlate with disease severity, but it's not a simple relationship. And so, you know, probably more virus means more infectiousness and more severity, but it's not necessarily a very clear-cut relationship. And we don't know that just yet.
Yeah. It probably also depends a lot which side of the body you're sampling, right? Because you're not sampling the whole body's viral load.
Right.
One site.
Right. And the sampling can be heterogeneous. You know, there's a sampling error and sampling bias and so on.
Man, so many layers of complexity. So being cognizant of time, I wanted to kind of move forward into a little bit about just modeling outbreaks in general and sort of what we've learned. So how did this, because there's been, you know, there were these stories about modeling is useless. The models didn't predict perfectly what happened. So your response to that and really what we've learned.
Yeah, I think so. The point of a model, and I'm going to limit this to forecasting models. So these are models that are designed to say what might happen in the future, in the immediate future, not necessarily mechanistic models that try and understand biological mechanisms. I think at the beginning of the outbreak, there was so little information available to policymakers to try to make decisions about course of action and interventions. And we knew a few things about the virus, but not a lot. And so the early models were really trying to formalize the thinking around what the observations that we had so far could mean for the spread of this disease. So, you know, there was a lot of criticism, partly because there were many weak models that were being used inappropriately, and that received a lot of criticism, and partly because the models were highly uncertain, just because the biology was so uncertain, and testing was such a disaster that we didn't know how many cases there were. And, you know, you can't make a good prediction about the future when you don't even know what's happening right now. So huge amount of uncertainty, both in the biology of the disease itself, as well as in kind of where we were. And so the models were really what we had in the absence of any other information. So yes, there were issues, especially with some of the model frameworks that were being used. But on the other hand, some of these models were the only things that policymakers had to go on to try and understand what might happen. So in those early days, there was just a huge amount of uncertainty all around, and the models were a framework to try and understand what could happen. And I think in that context, they were useful. Again, not helped by the proliferation of different models and confusion about what the goal of the modeling exercise was or what type of approach should be used and in what situation. Since then, there have been a number of other modeling approaches that have been very helpful, and those have been mechanistic. So, those have been asking questions about, okay, if we assume X about immunity, or we assume Y about the structure of social networks, what do we think will happen? And how can we use that information to make sensible policy decisions? And how can we use it to design better interventions? And I think those continue to be very helpful in thinking through the implications of some of our control strategies, and in thinking about what the future scenarios might look like. I don't think that these models should ever be seen as a definitive answer to be used in isolation from all the other political, economic, and epidemiological evidence available, but rather a tool to kind of examine the implications of your assumptions in a formal way and in a transparent way. And that to me is why models are useful. It's because they lay out very clearly what you believe to be true. And then they ask, what are the implications of those assumptions?
Are there any specific assumptions that you think were common, downfalls to why some of the early models didn't play out? Like, where did we guess wrong as a base case?
Well, I think there was some modeling approaches that didn't do well. So there were the underlying assumption behind those model approaches that didn't work well was that an epidemic in one place is going to be recapitulated in another place. And so we could just statistically copy the outbreak in Wuhan and overlay it onto populations in North America. And clearly that's not an appropriate set of assumptions. I think we have seen consistently super spreading events be a very critical part of this outbreak. And in the modeling sense, what that means is that your reproduction number, which is the number of cases that each case leads to, each case generates, is highly dispersed. So you have a lot of people that only spread the disease to one person, and then you have some people that spread the disease to many people, to many others. And so these super spreading events are important in determining the dynamics of the outbreaks. And I think we've come to appreciate how important those super spreading events are. So that's one thing. So I think one thing that really is very hard to capture in mathematical models, and that we have seen come to the fore as probably one of the most important aspects of this pandemic, is the importance of trying to incorporate human behavior more realistically into our models. So, it's very hard to predict human behavior during a crisis. And what we've seen is that some of the ways in which models have gone wrong is because we have not been able to anticipate some of the politicization, some of the behavioral responses among populations to the interventions, the spread of misinformation and what that has meant for trying to put in place common sense restrictions. That's something that was not easy to foresee, very difficult to put into the models in a reasonable way, and a large part of the uncertainty overall.
So models would typically assume perfect compliance?
Well, they would assume something like, some fraction of contacts are, reduced by some intervention. You can change what you assume about compliance, but in the absence of really being able to predict that, it's hard to estimate what might happen as a result of a particular policy.
So let's start wrapping up with just looking forward. And so what do you think will be, what do you see in your crystal ball, and what are the big factors that will determine the fate of the next, six months of this pandemic?
So I think the next 6 months is going to be defined by some of these social, behavioral, and political issues. Mm-hmm. I think from an epidemiological standpoint, we have a good idea of the basic parameters of this disease. We know some of the basic interventions that we need to focus on. The extent to which policymakers and the public will accept that and feel that they want to put those into place is very hard to predict. In the US, we have the election coming up in November, and there are all sorts of uncertainties associated with how politics and public health will interact leading up to that event, and subsequently into the winter. So honestly, I think that the biggest source of uncertainty is political at this point rather than biological. I do think that we have some promise that there's functional immunity. So I'm hopeful that there will be a vaccine of some kind. The scale up of that vaccine is going to be also very political and probably characterized by inequitable distribution. And that's something I worry about for next year. But overall, what that means is that we likely will have a vaccine, and there will come a time when we've brought this much more under control. So I don't have a crystal ball, but I think the winter is problematic. But I'm more hopeful for, this time next year.
So one last question on vaccines. How optimistic are you that we'll have enough uptake to reach herd immunity? Or do you see us reaching herd immunity through infection or through vaccine? Or how do you see those two playing the role in getting us there?
Again, this is because vaccine uptake depends on some of these social, political, behavioral things. It's hard to predict how that will go, and how misinformation about it will spread, how it will be politicized. So that's tricky. I do think that in places where we have reasonable uptake, we should be able to complement other non-pharmaceutical interventions with the vaccine and bring transmission down to a reasonable level. As far as whether herd immunity has been reached in some populations, I think it's possible in places, especially in low-income settings and in very poor communities. We've seen a very high number of cases, a very high burden of disease. And so then it comes down to the duration and efficacy of immunity and whether that's going to be enough. So probably there are pockets that have got there already, but we certainly need a vaccine to really bring this thing under control.
Is there any piece of misinformation as you wrap up that you would like to sort of address head on here that you see as particularly harmful, or any last messages that you feel like need to be heard more?
I think many of us have been quite disturbed at some of the misinformation about science and scientists and epidemiologists trying to push political agendas. And a lot of us have been working really hard all year to try to provide good information and to try to support policymakers. And so that's been disturbing. I think, I would emphasize that randomized controlled trials are really important for us to be able to understand how well new treatments and the vaccine will work. So we can't rush some of these things. This has been the most rapid proliferation of new vaccines and treatments and trials, probably in the history of the world. So the pace is very fast, but there are some things you can't rush, and we cannot tolerate risk in terms of safety and efficacy of these interventions for the sake of political will and rushing. And so I think I really hope that people understand that randomized controlled trials are not an attempt to slow down people's access to treatments. They are really designed to make sure that we don't endanger people and that we get the best treatments to people who need it.
Yeah, no. Oh, thank you, Caroline, for all your hard work. I know you and all of your peers are just giving 110% all the time.
It's tiring.
Well, thank you for your time, for fitting in one more thing on top of all the other demands you have. So I really appreciate it. It's been really educational. Okay.
Okay, thank you.
Take care.